Hello, everyone, and welcome to this webinar today as part of our continuing series on critical care webinars that we've started. Today, we are happy to have with us Dr. Atiya Dhala. She is an intensivist and the Director of Surgical Care, Critical Care Education at Houston Methodist, and also an Associate Professor of Clinical Medicine in Weill Cornell in New York. We are very happy that she accepted our invitation to speak to us today and share her expertise. And we look forward to hearing from you. So whenever you're ready, Dr. Dhala, please, you may begin.
Thank you so much, Dr. Moladina. Y'all can hear me well?
Yes, we can. Yes.
Excellent. Let me share my screen. And are you all able to see my screen?
Yes, we can see.
Perfect.
Zoom was download की गई दवा का डाउनलोड से ओपन किया कि जॉइन मीटिंग रखी
Okay. Good evening, everyone. My name is Atiya Dhala, and welcome to the Critical Care Monthly webinar series. The topic for today is cardiac involvement in sepsis and hemodynamic management. So the learning objectives for today will be: what is sepsis-induced cardiomyopathy? What is the optimal fluid for resuscitation in sepsis? What are the volume resuscitation endpoints in sepsis, and how can we achieve this? What is the optimal approach to the management of vasopressors? What is the ideal MAP goal, mean arterial pressure goal? And we'll just touch the surface of the use of point-of-care ultrasound in septic shock. So, in the United States, the management and across the world, management of sepsis has improved dramatically in the recent years. And so what we are seeing is a lot of people are surviving from the episode of sepsis in the hospital. More than 14 million patients in the United States actually recover from sepsis. But of these individuals that survive, 1 in 4 of these older survivors are discharged to a post-acute care facility. And 40% of these are readmitted within 3 months. And 1 in 5 of these survivors has a late death that is not even explained by their pre-sepsis health status. So what I'm trying to say is many of these survivors have poor long-term outcomes, and they can have, worsening neuropsychological impairments. They have physical disabilities. They're vulnerable to health deterioration, recurrent infection, cardiovascular events, acute renal failure. So the purpose of this talk is to recognize this condition early, treat it adequately, and that's what we're going to go through the talk today. So I guess you guys are all familiar with this our one bundle from the Surviving Sepsis campaign, where we have a patient with sepsis and septic shock. We measure the lactate levels, we obtain blood cultures, we administer broad-spectrum antibiotics. We begin rapid administration of fluid, about 30 mLs per kilogram of crystalloid for hypotension. And then we apply vasopressors if hypotensive during and after fluid resuscitation to maintain a mean arterial pressure of greater than or equal to 65. And we're going to work through all of these and discuss in detail why these recommendations came about. My focus of today is going to be about recognizing sepsis-induced cardiomyopathy. So cardiac involvement is one of the most frequent complications of sepsis. And sepsis-induced myocardial dysfunction or cardiomyopathy is defined as intrinsic myocardial systolic and diastolic dysfunction of the left and right sides of the heart that are induced by sepsis. And that our changes are seen at the cellular and the molecular level that result in malfunction of the myocardium. By definition, a sepsis-associated acute syndrome of cardiac dysfunction is unrelated to an acute coronary syndrome or ischemia of the heart. And it has one or more of these main characteristics. So you can have LV dilatation with normal or low filling pressures. You can have decrease in ventricular contractility, and it could be right ventricle or left ventricle, systolic or diastolic dysfunction. And you'll see this based on a decreased responsiveness to the fluids that you're giving them, or a decreased responsiveness to the catecholamines that you're giving them. And the presence of septic cardiomyopathy is a relevant contributor. Once you develop this dysfunction, you're going to see a lot of organ dysfunction that results from this. And this is an important factor complicating the management of patients with sepsis. Usually, sepsis cardiomyopathy is acute and reversible within 7 to 10 days. So the definition of sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. So in general, sepsis-associated cardiomyopathy develops secondary to an excessive host response to an infection. Although we talk about lipopolysaccharide as an important circulating myocardial depressant factor, myocardial dysfunction is not only related to gram-negative sepsis. As you know, there's equal amounts of gram-positive and gram-negative sepsis. The systemic inflammatory reaction in sepsis is induced and sustained by these ligands or mediators called DAMPs, danger-associated molecular patterns, and they circulate in the blood and trigger a systemic inflammation. The presence of a pathogen is then recognized by the host by these toll-like receptors, the TLR. And these are expressed in immune cells and other cells, including the cardiomyocytes, and interact with different PAMPs or pathogen-associated molecular patterns, leading to activation of NF-kappa B or the nuclear factor kappa B, and then subsequent formation of pro-inflammatory cytokines. Another mechanism of the pathophysiology in septic cardiomyopathy is the excessive formation of nitric oxide and reactive oxygen species. Under physiological condition, calcium enters the myocardiocytes through the L-calcium channels. And that is, the calcium gets released from the sarcoplasmic reticulum during electromechanical coupling. But what happens during septic cardiomyopathy is that there is a dysregulation of this, which results in a decreased contractile force. There's also a problem with mitochondrial dysfunction, further contributing to sepsis cardiomyopathy. So how do we clinically diagnose septic cardiomyopathy? You know, when we look and we see that we're giving fluids to these patients, but they're not having a good blood pressure response. We're seeing deteriorating hemodynamics under increased use of vasopressors and inotropes. We're seeing tachyarrhythmias. We're seeing signs of inadequate perfusion, right? Rising lactate, decreased mixed venous saturations, decreased capillary refill time, etc. So the things that we have available in our units are the static parameters, right? Like we use the blood pressure cuff. And what the blood pressure cuff calculates, it uses a method called the oscillometric method to calculate the mean arterial pressure. And so after it calculates the mean arterial pressure, there are algorithms to actually then figure out what is the systolic and diastolic pressure. And what mean arterial pressure is calculated as 1/3 systolic blood pressure plus 2/3 diastolic blood pressure. The other way to calculate static parameters are the use of an arterial line, where we look at continuous blood pressure and mean arterial pressure monitoring. Now, mean arterial pressure is important, and it's regulated by changes in many things, as you can see: cardiac output for one, systemic vascular resistance. And this scheme basically summarizes the factors that regulate mean arterial pressure through cardiac output, systemic vascular resistance. Then in some ICUs, I mean, of course, this is going out of fashion and we don't use this a lot, but if you were to place a pulmonary artery catheter, you also will get a lot of data points out of it, like systemic vascular resistance, cardiac output, mixed venous saturation. Central venous pressure monitoring has been used for a very long time, but it has been shown to poorly correlate with left ventricular and diastolic pressure. So can we use something that we use, like an arterial pressure waveform, and use that to have more physiological monitoring of this arterial waveform? So there are a lot of algorithms and devices available that actually will understand the structure of the arterial waveform and look for changes in these waveform characteristics based on left ventricular stroke volume changes, based on vascular compliance changes, based on systemic vascular resistance changes. And if you look at these waveforms, they look different. And a lot of companies have proprietary algorithms where they look at arterial pressure-based cardiac output algorithm, APCO, where they can look at different aspects of the arterial waveform, and based on the algorithms will actually be able to tell you what is the stroke volume, what is the systemic vascular resistance, and by after the stroke volume is calculated, if you multiply it by heart rate, that gives you cardiac output. And systemic vascular resistance is mean arterial pressure minus central venous pressure divided by cardiac output times 80. And so a lot of these algorithms and devices are available for non-invasive calculation of hemodynamics at the bedside. So in septic shock, what are the effects on cardiac output? So a lot of the times we see there's an absolute hypovolemia or a relative hypovolemia. So when we look at the hemodynamics in somebody with septic shock, you want to make sure to understand, what do we think is the preload of this individual? What is the afterload of the individual? And by afterload, I mean the systemic vascular resistance. So what is systemic vascular resistance? It's an estimation of the afterload of the left ventricle, or the afterload is basically defined as the force that impedes or imposes left ventricular contraction. So in septic shock, what happens to the afterload? There's a reduction, there's a severe reduction in afterload because of the vasodilatory systemic inflammatory response that's going on. So if your afterload is very low, there really is nothing obstructing the output of the left ventricle. So the left ventricle really functions at a very high degree. Now, and you may mask cardiac dysfunction because you're looking at the ejection fraction and cardiac output because it's reaching its maximum physiological limit to compensate to maintain blood pressure in the setting of a very low SVR. But when you start to see that the cardiac output is normal when the SVR is low, like for example here, normal LVEF when you have a very low afterload, or it's a low LV ejection fraction as you start giving the patient vasoactive substances and increase the increase the systemic vascular resistance, and then the cardiac output drops, then you're really unmasking some degree of cardiac dysfunction in these individuals. So it's really cardiac function or cardiac performance based on the afterload, is the point that I'm trying to drive at. So how do we direct our treatments in septic shock? I think the first topic I'm going to discuss is fluid selection. Is it crystalloid? Is it colloid? Is it both? So these are the types of fluids that we all use. Normal saline, I like to call it abnormal saline because really the sodium and the chloride is much higher than physiology. Our normal body sodium is 136 to 145. This is 154 milliequivalents. Normal body chloride is 96 to 105. This has 154. And the pH is 5.0. And the osmolarity is higher than serum osmolarity at 308. So typically, this type of fluid is not used a lot in the United States, and we are trying to go more for the balanced solutions. And so we'll talk about what the data is out there for this. Lactated ringers is a balanced solution. The pH is 6.5. It has a little bit of potassium. The sodium is 130. Chloride is 109, and the osmolarity is 275. Plasma-Lyte is a balanced solution, which is very much like what we have physiologically in the body, and with a pH of 7.40, with an osmolarity that matches our human serum osmolarity. So let's talk about the studies comparing balanced crystalloids versus abnormal saline. The SMART trial. The SMART trial was published in the New England Journal of Medicine 2018, and it was a pragmatic, unblinded study. And it compared almost 8,000 patients in the intervention arm that received the balanced crystalloids versus another 8,000 patients in the control arm that received normal saline. And what they looked at was the occurrence of a composite endpoint that they called MAKE 30. And this stood for Major Adverse Kidney Events in 30 days. And the composite was mortality, new need for renal replacement therapy, and persistent renal dysfunction in critically ill patients. And what they found was that the biggest difference they saw in this composite outcome of MAKE 30 was noted in septic patients and in those receiving larger amounts of volume resuscitation, suggesting that the benefits may be greater using balanced crystalloids in this population. And in a subset analysis, they found that there was a mortality benefit suggested in septic patients that were treated with balanced crystalloids. This is another fluid trial where they compared a restrictive fluid strategy versus a liberal fluid strategy for patients with sepsis-induced hypotension. This was the Clovers trial that was published in the New England Journal just very recently. And this is also a multi-centered, randomized, unblinded, and they were looking for a superiority trial and they compared restrictive fluid strategy where they gave restricted fluids but used more vasopressors, and they used fluids as a rescue, about 800 patients. And then the liberal fluids used a lot more fluids, and they used vasopressors for rescue. And the outcome did not actually show any significant mortality difference, either lower or higher, before the patients were discharged home by day 90 than a liberal fluid strategy. If you look at the data from the Clover's trial, there was no change in mortality. Of course, in the restrictive fluid, they had much less fluid compared to the liberal fluid group. Vasopressors were more used in the restrictive fluid group than in the liberal fluid group. And there was no really statistically significant difference in serious adverse events. So the conclusion from the Clover's trial is in patients with sepsis-induced hypotension, a restrictive fluid strategy that prioritized vasopressors in the first 24 hours after resuscitation did not result in significantly lower or higher mortality before discharge home by day 90 than the liberal fluid strategy. And there are many other studies out there. I'm just giving you a glimpse of all the of some of the major studies. What about albumin? So there's a robust body of evidence evaluating the effects of albumin in patients with sepsis and septic shock. And this has resulted in the Surviving Sepsis campaign of using albumin in addition to crystalloids for initial resuscitation and then subsequent volume replacement when patients require substantial amounts of crystalloids. And this was published in Intensive Care Medicine 2017. This recommendation is largely based on this trial, the ALBIOS trial, that showed that albumin may be associated with decreased mortality in a subgroup of patients with septic shock and hypoalbuminemia. Importantly, in the ALBIOS trial, albumin was administered in hypoalbuminic septic patients in an attempt to maintain serum albumin of 3 or more. And in addition, albumin was given at a daily dose of about 300 ml of the 20% albumin for 7 days. The SAFE trial, that is the saline versus albumin fluid evaluation trial, showed no benefit to albumin in the overall survival, but it did show a decreased mortality in a subgroup of patients with sepsis. Now, I wanted to show you the different types of albumin that we have available. You have the 5% albumin, and if you want to use more volume, then I would choose the 5% albumin, and this is 250 mLs. 250 ml is the 12.5 grams, and if you take the 500 ml bottle, that is 25 grams. And the little bottles are the 25% albumin, 50 ml bottle is 12.5 grams, and the 100 ml bottle is the 25 grams. So these are the two types of albumin we're talking about. Now, there was a meta-analysis of multiple randomized controlled trials published in the Journal of Intensive Care Medicine 2023. And this was to evaluate the effectiveness of different concentrations of albumin compared to crystalloids in reducing mortality in sepsis and septic shock patients. And they included a total of 8 randomized controlled trials covering more than 5,000 septic and more than close to 3,500 septic shock patients. And they found that albumin treatment, particularly 20% albumin, significantly decreased the 90-day mortality in septic shock patients. Both 4 to 5% and 20% albumin may work better than crystalloid in improving the survival of patients with sepsis. But they also went on to say that there is more randomized controlled trials that are needed for validation. So these were the forest plots for the RCT meta-analysis showing survival benefit from 4 to 5%, with 4 to 5% albumin, and also with 20% albumin. So how do we best resuscitate our patients? You know, should we do a protocolized therapy? And so the now 23-year-old study, and I remember this so well and practiced it religiously was the early goal-directed therapy in the treatment of severe sepsis and septic shock by Emmanuel Rivers and group. And basically, they taught us how to use crystalloids and then colloids and add vasoactive agents in a stepwise protocolized fashion based on central venous pressure, mean arterial pressure, and mixed venous saturations. And now, this study has been criticized quite a bit. We don't really have to put in, and check CVP monitoring, because CVP monitoring doesn't really correlate very well with volume status or left ventricular and diastolic pressure. So this study has become very controversial. Following this protocolized study, there were 3 other triad of sepsis protocolized studies: the PROMISE from the UK, the PROCESS from the US, and the ARISE from Australia and New Zealand, that again showed that protocolized therapy was not better than standard care. Then there was a meta-analysis that took all the individual patient data from all of these 3 studies, and they also showed that there was no improvement in mortality using protocolized versus usual care. So then how should we resuscitate? Is there a different method that we are using nowadays to resuscitate these patients? Should it be guided by dynamic measures, maybe, to prevent volume overload? So I'll talk a little bit about IVC, pulse pressure variation, passive leg raise, and the capillary refill time. And we're also going to go over how do we determine the optimal amount of fluid, and using these dynamic variables, can we do a different type of protocolized therapy than done by, Rivers et al. And by the triad of sepsis studies? So, the most difficult thing to do is to find out what is the optimal amount of fluid a patient needs. So if you look at the fluid on the x-axis and the complications on the y-axis, you'll see that if you give too little fluid, you're going to cause tissue hypoxia, hypoperfusion, organ failure. But then on the other hand, if you give too much fluid, you're going to cause tissue edema, pulmonary edema. You're going to cause abdominal compartment syndrome. You're going to increase ventilator days and then increase mortality. So let us try to understand the phases of shock and the 4-hit model of shock. And this may be able to help us figure out how we resuscitate these patients. So septic shock usually starts off with the ebb phase, which refers to the phase where the patient is in hyperdynamic shock. There's increased capillary permeability. There's a decreased systemic vascular resistance. There's vasodilation. And there's a relative intravascular hypovolemia. And then there is the flow phase, which refers to the phase after initial stabilization, when the patient is able to now seal their capillaries and then mobilize the fluids more spontaneously. There is the graph below where it shows the 4-hit model of shock with the ebb and flow phases. And there's also phases of resuscitation. So based on the type and the stage of the shock, the type of resuscitation will also vary. So in the initial phase, you're going to do a lot of, if the patient is hypovolemic, so you're going to do some resuscitation. And then you're going to optimize. And then by optimization, you will then be followed by a phase of normal volemia. If you continue to do fluids without assessing the patient every time you give a bolus or assess the need for giving a bolus, then you will reach a stage where you will reach overload. And then you may have to do something called de-resuscitation to achieve the state of normal volemia. And then if you de-resuscitate too aggressively, you could risk organ hypoperfusion again. So all of these stages have to be done with some degree of precision. So what I'm trying to say is that we really need to think of fluid as a drug. So if it's a drug, we need to know what dose we need to use, we need to know the duration, and when do we stop? When do we de-escalate? So the 4 questions we ask ourselves: when do we start the fluids? When do we stop the fluids? When do we start de-resuscitation? And when do we stop the de-resuscitation? So I was going to present the thing that I do very, very often, this bedside test, so easy to do, not affected by, you can do it on a patient on a ventilator, not on a ventilator, and really not affected by many things, is to really do what we call the passive leg raise. So if a patient's lying at 45 degrees, you bring their head down and you elevate the legs to 45 degrees. And by doing that, you're redistributing the volume that's in the lower extremities and moving it more central. And if you were to look at, as I previously talked about, you look at your arterial pressure waveform, and you look at the different shapes of it, and there are certain algorithms that will help you figure out your stroke volume. And by looking at the stroke volume, you can assess. And so you assess a baseline stroke volume, you do the passive leg, and you look and see if there was a change in stroke volume. Okay, and you want to see at least a 10% change in the stroke volume. And if that is attained, then it tells you that this patient might be fluid responsive. So I'm going to talk about this trial called the FRESH trial that basically tries to answer this question. Will resuscitation that is guided by dynamic assessments of fluid responsiveness in patients with septic shock improve patient outcomes? So this study was published in Chest 2020, called the FRESH trial. It's a multi-center randomized controlled trial. It studied septic shock patients in a 2-to-1 fashion in 13 hospitals in the United States and the United Kingdom. And they looked at septic shock treatment guided by this passive leg raise. And they had 83 patients in the intervention arm and 41 patients in the comparator arm. And what they looked at was fluid balance at 42 hours or ICU discharge, and they found that was significantly lower, favoring the intervention arm. And there were fewer patients that required dialysis, a continuous dialysis, renal replacement therapy, or mechanical ventilation, and patients were more likely to be discharged home alive. So the way they did this study was they looked at patients with septic shock that were initially resuscitated after the fluid bolus, or 30 mLs per kilogram, and then for future boluses, they used the passive leg raise. If the patient had a change in stroke volume by greater than 10%, then they would give the patient a fluid bolus. If the patient did not have a change in stroke volume, then they would actually add vasopressors because they felt that maybe the patient was not fluid responsive and that they may have a decreased afterload or SVR. And so then they used vasopressors to help with the septic shock. And they titrated their pressors and they kept checking for fluid responsiveness throughout. And then they adequately dose the fluids based on responsiveness or not. And so physiologically informed fluid and pressor resuscitation with the use of the passive leg raise induce stroke volume change to guide personalized management of sepsis-associated hypertension. They found that this was quite safe. Among patients who met pre-specified enrolled criteria and treated with this dynamic measure-guided resuscitation, they had a lower net fluid balance and reduction in the risk of renal and respiratory failure. And that functional evaluation of fluid responsiveness identified a group of patients with sepsis-associated hypotension who should not have further IV fluids infused. However, it did not improve survival in the study, but at least it gave us a body of literature and evidence to show the harms of excessive fluid administration and positive fluid balance. So this is a very important study. We use this a lot at the bedside, using the passive leg and then looking for fluid responsiveness. So, it's very important in septic shock that we resuscitate as soon as possible, because greater delay will result in greater physiological stress, organ injury. There are other things, dynamic things that you can look at to assess organ perfusion. And one of the markers by the Surviving Sepsis Guidelines was the use of serum lactate. The other monitoring parameter you could use at the bedside is something called a capillary refill time. And the reason to check this is that, when you have a shock state, the body will attempt to restrict the blood flow in the peripheral vascular beds. So one way of checking is, if you have an improvement in capillary refill time, that is one of your measures that you are resuscitating this patient adequately. So how do you do this? You basically take the pulp of the finger and then press it down either with a slide or just with your other fingertip. And capillary refill time should be within 3 seconds. So you press it down for about 10 seconds and let it go. And within 3 seconds, it should fill. A delayed filling will be much longer, as you can see on this side. This patient is really taking a very long time for the capillary to refill. So there was a trial, and the objective was to determine if a peripheral perfusion targeted resuscitation during early septic shock in adults is more effective than the lactate level targeted resuscitation for reducing mortality. And this was the Andromeda shock trial published in JAMA 2019. Again, a multi-centered randomized trial. And so the intervention was resuscitation based on capillary refill time, and the comparator was resuscitation based on normalizing lactate. And what they found was that at 28 days, the mortality was 43.4 in the lactate level guided group and 34.9 in the capillary refill time group. Although this was not statistically significant, it gives you another parameter to assess for targeted resuscitation of these patients. What about vasopressors? I'm going to just talk for a minute on this, because you know this quite well, that the initial pressor of choice is norepinephrine. And then vasopressin is added. And then beyond that, it's depending on what your algorithm determines. Most of the time, we'll add epinephrine. And then if there is a cardiomyopathy, there is a role for ionotropes, which I've not included on the slide, like dobutamine. And the one thing we don't use, and all the studies negate, is the use of vitamin C. This is one of the algorithms proposed by the Society for Critical Care Medicine on the escalation of vasopressors. So by doing all of this resuscitation using vasopressors, what then should be your mean arterial pressure goal? And so the 65 trial nicely summarized this. This was published in JAMA 2020. And what it looked at was the effect on mortality at 90 days of reducing the exposure to vasopressor through something called permissive hypotension. So they targeted a MAP goal of 60 to 65 in ICU patients age 65 or older receiving vasopressors for vasodilatory hypotension. And this was studied in 65 adult ICUs in the United Kingdom. The mean age of these patients was 75 years. And they looked at permissive hypotension versus usual care. And their primary outcome was all-cause mortality at 90 days. And what they found was that permissive hypotension did not risk the patient, and that and actually did not significantly reduce mortality, but also was of no risk to the patient. And the one thing it did achieve, though, was it took off the vasopressors by 5 hours. So the patients in the permissive hypotension group had 5 less hours of vasopressors. Now I'm going to briefly touch on how we use POCUS based on what the echo parameters in septic cardiomyopathy are. One is it can have a decreased cardiac output, you can have RV dysfunction, you can have left ventricular dysfunction, either systolic or diastolic dysfunction. So if you were going to use point-of-care ultrasound, we image the heart in these different planes. I'm going to focus just on the long axis or the sagittal view, where we divide the heart into the right and left portions. So for that, we're going to use this view called the parasternal long axis view. And in the parasternal long axis view, the left ventricle is on the left side of the long view. That's how I remember it. And so this is the left ventricle. And with your eyeball, you can look at how the myocardium thickens and thins, how the mitral valves open and close. And this is the aortic valve, and this is the right ventricle. So if you were going to look at different, so this is a normal. This is a patient in septic shock that's very hyperdynamic. As you can see, it looks like this patient needs volume. This is a patient whose heart function is not quite as robust as up here. So this is a lower ejection fraction, like 45–50%. And here is a patient with severe cardiomyopathy. You can see that end systole and diastole, there is not much change in the size of the left ventricle. The other thing you can look at is the IVC. So in the subcostal view, if you put your indicator marker pointing towards the patient's head, and then you tilt the probe, you will find the IVC. And this is a patient who's having, changes in the IVC with respiration. Here is another look at the IVC. This looks like a patient that might be fluid responsive. Here is a patient where the IVC does not change at all with respirations. So this is what we call a plethoric IVC. You can put an M mode on the IVC and look at the minimum and maximum diameter of the IVC and put it into a calculation called the IVC distensibility index. And this is for use in patients on positive pressure ventilation. And if you see a change of 18%, it tells you that this patient is a fluid responsive patient. Now, in a spontaneously breathing patient, even though this looks like a big change in the IVC with breathing, it's really not very helpful because of so many things: the way the patient takes the breath, the resistance to the breath, the compliance of the lung, the pattern of the chest wall movement versus the abdominal movement. There are so many things that play a role in how the changes in the IVC happen. But if you see an IVC, which you can, what we call a virtual IVC, you cannot see it at all, then in a spontaneously breathing patient, that would mean that this patient is fluid responsive. So if you see a patient that's like this, very hyperdynamic, and you can see the IVC collapsing, it would probably mean that this patient is needing fluids. In this case, very poor LV function with a plethoric IVC. It's probably not somebody I would give fluids to. Then the next thing I was going to show you is the another parameter that you can look at. This is the RA, this is the LA, and this is a normal functioning heart. And if you then tilt the probe down and get a 5-chamber view, you'll be able to study something else called the stroke volume. And you're basically looking at ejection of a cylinder of blood volume out of the left ventricle through the aortic valve. And to calculate the volume of a cylinder, and I'm going to deconstruct this, is basically pi r squared times the height of the cylinder. So basically you're calculating the volume of the cylinder. And that volume in this case happens to be the stroke volume. It is complicated, but let's just look at how we quickly calculate pi r squared. Pi is 3.14. To get the r, the radius, you have to figure out the diameter. So in parasternal long axis view, this is where the aortic valve is. If you zoom in, you can measure the diameter. Divided by 2 gives you the radius, and then you square the radius. And that gives you pi r squared. And to calculate the height of the cylinder, you do the velocity time integral calculation. You have to put a pulsed wave Doppler at the LVOT, the left ventricular outflow tract, and figure out what the velocity time integral is. And the normal is usually 18 to 25. And then you can use the same passive leg raise, look at your VTI, and then do a passive leg raise, and then look at the VTI after the passive leg raise. And then you'll be able to determine, so in this case, it was 16.4 before the passive leg raise, and after the passive leg raise, the VTI increased by 36%, showing that this patient is also fluid responsive. And if you look at the ROC curves, you would see that the change, anything that is dynamics, if you see a change in cardiac output, change in stroke volume, it's way better than the static tests that we do. And so with that, I'll close. And I think what we've discussed today is the guidelines by the Surviving Sepsis campaign. And this is all done to improve mortality from patients with sepsis and septic shock. And that sepsis is a time-dependent condition in which hourly delays in diagnosis or initiation of effective treatments are associated with adverse outcomes and higher costs. We've talked about the optimal fluids for resuscitation in sepsis. We've talked about dynamic parameters that we can use to achieve our volume resuscitation endpoints. And we've also talked about what is an ideal mean arterial pressure goal. And now I'd like to, stop talking and open it up to questions that you might have. Thank you so much for your attention.
Thank you, Dr. Dhala, for that excellent presentation. Very, very practical tips for us to use the choice of fluids and the amount of fluids, the goals of resuscitation. So, yeah, very, very interesting. We have a few questions. We have a few questions on the chat, so I will start with those, and then if anyone else has other questions, then we can allow that you guys to speak as well. So the first question is, someone asks, is if we are suspecting cardiac dysfunction in sepsis, do we expect any abnormal ECG tracings?
Yes. And so if you look at the ECG, you will see either the patient will have SVT, supraventricular tachycardia. We've also seen in quite a number of patients the development of atrial fibrillation. And those could be just as a result of sepsis cardiomyopathy. It could also be the choice of vasopressors. So that may be a time when you use escalating doses of norepinephrine, and you're getting into the tachyarrhythmias is when you want to add a non-catechol, like a vasopressin, to the regimen to decrease the, the beta action on the heart.
Thank you. So this is a question that I think many of them also had. So we are limited by the resources that we have in Tanzania in our ICUs. So one of the things that you mentioned that we can use is cardiac output or stroke volume to assess whether the passive leg raise is going to give us any, to assess fluid tolerance, basically, using the passive leg raise. But what is your opinion for those in low resource settings where it's difficult to measure a stroke volume or a cardiac output directly? Can we then use other measures like blood pressure for assessing tolerance to passive leg raise?
I think you can. It's just that the problem is there'd be too many variables in a non-intubated patient. If it's an intubated patient, I think it'll be more reliable to check. But in a patient that's not intubated, because of the variation in the way the inspiration occurs or the type of breath the patient takes, I think the changes would be quite different. But the passive leg raise can definitely be used. If you have an arterial line or an arterial pressure waveform, I've used that to check and see a change in the blood pressure, like the arterial pressure. And sometimes what I do is I speed up the waveform and I look at the fluctuations of the tips of the A line. But those are not validated measures for fluid responses. Actually, I think you can use capillary refill time, lactate, and if you have echo, POCUS, I think might be a good way if we don't have other parameters to assess stroke volume.
Yeah, thank you. So a follow-up to that. So if you do use blood pressure as a surrogate for your tolerance, what would your cutoff be? Would you say use the same 10% increase in, let's say, if it's systolic blood pressure?
Yeah, something like that. Keeping just be aware that the mean arterial pressure from that previous slide I showed, cardiac output, systemic vascular resistance. What is cardiac output? Is stroke volume times heart rate. So all of these things, so the heart rate goes down, blood pressure goes up. I think those are good things. I also use touch the patient's extremities to see what is their systemic vascular resistance, kind of, if is it cold? Is it warm? Is it a vasodilation? What's going on? Capillary refill, I think, is great. So I think not having just one parameter, but having multiple parameters may be beneficial. How is the urine output? What is the lactate doing? Are my peripheries better perfused now? I think that will be more than just looking at one static blood pressure parameter.
Yeah, thank you. I think I agree. So I think one thing that we should we always learn is that it's not just one measurement that helps us guide decisions in the ICU. It's usually a number of different things and the trends of all these values that gives us better. If I could ask, we said normal saline or abnormal saline is not the best choice, but is there any situation where lactated ringers would not be the best option as well? Because these are the two main ones that we have in Tanzania.
Yeah. So, I think lactated ringers is a great choice. It's the only time I work in a surgical and liver transplant ICU. So the only time I don't use LR is because, the lactate gets converted to bicarbonate. And when we have liver dysfunction, that doesn't happen very well. Other than that, I really love lactated ringers, and I think it's a great choice. I just don't think in this day and age normal saline is such a great idea, just because of the hypochloremic acidosis and and all these abnormalities that happen with using a lot of normal saline.
Can we use pulse pressure variation? I think that's what you alluded to in the A line.
Yes, I think you can absolutely do that. Just knowing that the studies have not fully validated that in a non-ventilated patient, just because with positive pressure ventilation at least 8 cc per kilo, that change makes more sense from the peak to peak variation than in a spontaneously breathing patient.
Okay, thank you. If anyone has any questions, they want to unmute themselves, you're welcome to do that. I'll give you a few seconds before I. Okay, looks like we don't have any more questions. So yeah, thank you very much, Dr. Dhala, for this very, very important session. I think there's a lot of people saying thank you in the chat, and rightfully so. It was very informative for us and very useful practical tips. And we look forward to having you back again for another session in the future sometime.
Would be absolutely my pleasure, and I thank you very much. And feel free to email me if you have any questions regarding this. I guess should I put it in the chat, or Dr. Moladina, would you be able to just share my email with everyone?
Yes,
And you feel free to send me questions if you have any.
Sure, definitely, yes.
Okay.
If anyone thinks
All
of
right.
questions later on, yeah, feel free to send it to me, and then I can forward it to Dr. Dhala. And if you have also ideas for future topics that you might want to hear about, then feel free to also write to me or email me, and then we can try and include it in our schedule as well. So yeah, thank you very much, everyone, for attending. Thank you, Dr. Dhala, once again, and have a good evening, everyone.
Thank you, Dr. Moladina, for inviting me. I'm very honored. Thank you so much.